This recording will go over cystitis and urethritis. Cystitis is an inflammatory condition of the bladder. Commonly, it refers to inflammation from an infection of the bladder. However, cystitis can be caused by inflammation without infection. An infection can occur in any area of the urinary tract and the kidney. Such infections are known as urinary tract infections or UTIs. Please review Table 66-3 that goes over risk factors for UTIs. An acute UTI is the invasion of a normal urinary tract by an infectious organism. A recurrent UTI occurs as more than 2 infections in 6 months or more than 3 in a year. The distinction in UTIs is important because they have different approaches to management. A UTI is further categorized as uncomplicated or complicated. With an uncomplicated UTI, there is no anatomic or functional abnormality of the urinary tract or condition that increases the risk for infection or the possibility of treatment failing to resolve the infection. Some factors and conditions that contribute to a diagnosis of complicated UTI are pregnancy, male gender, obstruction, diabetes, neurogenic bladder, chronic kidney disease, and reduced immunity. In men, a UTI is generally considered complicated, even with normal structure and function, because most UTIs occur in older men or in association with anal intercourse. Complicated cystitis or other UTI requires greater vigilance to avoid or detect adverse events from the infection and a longer course of antimicrobial treatment. The presence of bacteria in the urine is bacteriuria and may occur with cystitis or any UTI. The urinary and genital urinary tracts are normally sterile apart from the distal urethra. Several host defenses help protect against infection in the urinary tract. Mucin produced by cells lining the bladder helps maintain mucosal integrity and prevents cellular damage. Mucin prevents bacteria from adhering to urothelial cells. Urine pH and the concentration of organic acids also contribute to sustaining sterile urine. Leukocytes in the urinary tract are the immunity cells that engulf and destroy pathogens. Urine proteins, such as secreted antibodies, also are protective. In men, the prostate gland secretes additional protective proteins. Frequent voiding is another defense against bacterial growth and adherence by preventing urine stasis. UTIs, like other infections, result from interactions between a pathogen and the host. Usually, a high bacterial virulence, or ability to invade and infect, is needed to overcome normal host defenses and immunity. However, an adult with reduced immunity is more likely to become infected, even with bacteria that have low virulence. With UTI, bacteria move up the urinary tract from the external urethra to the bladder to cause infectious cystitis. Less commonly, the spread of infection through the blood or lymph fluid can occur. Infectious cystitis typically is caused by pathogens from the bowel or, in some cases, the vagina. About 90% of UTIs are caused by E. coli. Candida is another infecting microbe. Catheters are the most common factor associated with new onset UTIs in the hospital or long-term care settings. Within 48 hours of catheter insertion, bacterial colonization along the urethra and the catheter itself begins. About half of patients with an indwelling catheter become infected within 1 week of catheter insertion. How catheter-associated infection occurs varies between genders. Bacteria from a woman's perineal area is more likely to ascend to the bladder by moving along the urethra. The shorter urethra in women aids in the ascending organism's migration. In men, bacteria tend to gain access to the bladder from the catheter itself. Any break in the closed urinary drainage system allows bacteria to move through the lumen of the catheter. The external catheter surface also provides route for migration. Best practice to reduce the risk for catheter contamination and catheter-associated UTIs is listed on Chart 66-7. Please review Chart 66-7. It has important information about minimizing catheter-related urinary tract infections. Organisms other than bacteria can cause cystitis. Fungal infections, such as those caused by Candida, can occur during long-term antibiotic therapy because antibiotics change normal protective flora that reduce the adherence and volume of pathogenic bacteria. Patients with reduced immunity who are severely immunocompromised, are receiving corticosteroids or other immunosuppressant agents, or have diabetes or AIDS are at a higher risk for fungal UTIs. Non-infectious cystitis may result from chemical exposure to certain drugs, from radiation therapy, and from immunity problems, as with patients who suffer from lupus. Interstitial cystitis is a rare chronic inflammation of the entire lower urinary tract that is related to genetic and immunity dysfunction rather than infection. Symptoms are pain associated with bladder filling or voiding, usually accompanied by frequency, urgency, and nocturia. Although cystitis is not life-threatening, infection of the urinary tract can lead to life-threatening complications, including pyelonephritis and sepsis. So with cystitis, your infections in the lower urinary tract and systems with the bladder, right? Pyelonephritis refers to inflammation or infection of the kidney. So when that infection that moves up the urethra, the bacteria move up the urethra, start reproducing in the bladder, causing problems. If that continues to spread up into the kidneys, that can be very, very problematic and serious for the patient and can lead to sepsis. Severe kidney damage from an ascending UTI is a rare complication. Patients with predisposing factors such as anatomic abnormalities, pregnancy, obstruction, reflux, calculi or stones, or diabetes are at greater risk for complications. The spread of infection from the urinary tract to the bloodstream is termed bacteremia or urosepsis. Please review Chart 66-9 Key Features of Urinary Tract Infection on your own. Please also review Chart 66-8 Preventing a Urinary Tract Infection. Laboratory assessment for UTI begins with a clean catch urine specimen. The combination of a positive leukocyte esterase and nitrate from a urinalysis is indicative of a UTI. The presence of white blood cells, or pyuria, red blood cells, or hematuria, or CAS may also indicate UTI. The presence of more than 20 epithelial cells suggests contamination, and a new specimen should be collected. A urine can also be cultured to determine which type of bacteria or infectious organism is growing in it, and then a sensitivity would indicate which medication could best be used to treat the infection. Occasionally, the serum white blood cell count may be elevated, with a differential white blood cell count showing a left shift. The shift indicates that the number of immature white blood cells is increasing and the number of mature white blood cells is decreasing in response to continued infection. Thus, the number of bands or immature white blood cells is elevated, which indicates reduced immunity. Left shift most often occurs with urosepsis and rarely occurs with uncomplicated cystitis, because cystitis is a local rather than a systemic infection. The diagnosis of UTI and cystitis is based on history, physical examination, and laboratory data. If urinary retention and obstruction of urine outflow is suspected, pelvic ultrasound or CT may be needed to locate the site of obstruction or the presence of calculi or stones. Voiding cystourethropy is needed when urine reflux is suspected. Cystoscopy can be used to evaluate recurrent UTIs. Cystoscopy identifies abnormalities that increase the risk for cystitis. Retrograde pylography, along with cystoscopic examination, shows outlines and images of the drainage tract. Cystoscopy is needed to accurately diagnose interstitial cystitis. Non-surgical management includes interventions for the management of cystitis, focusing on comfort and teaching about drug therapy, fluid intake, and prevention measures. Drugs used to treat bacteriuria and promote patient comfort include urinary antiseptics or antibiotics, analgesics, and antispasmodics. Fluconazole is the drug of choice for the treatment of candida fungal infections. Antispasmodic drugs such as hyoscyamine decrease bladder spasms and promote complete bladder emptying. Antibiotic therapy is used for bacterial UTIs. Guidelines for uncomplicated cystitis recommend nitrofurantoin, trimethoprim sulfamethoxazole, or fosfomycin as first-line therapy. Phenazopyridine is an analgesic that can help to relieve discomfort with urination for patients who are suffering from UTIs. Patient teaching would include teaching the patient that discoloration of the urine, a red or orange discolorization, is a normal expected side effect of the medication. Urge patients to drink enough fluid to maintain dilute urine throughout the day and night unless fluid restriction is needed for other health problems. Some urologists recommend sufficient fluid intake to result in at least 1.5 liters of urine output or 7 to 12 voidings per day. Cranberry-containing products taken daily appear to decrease the ability of bacteria to adhere to the epithelial cell lining the urinary tract. Cranberry juice, tablets, or capsules must be consumed for more than 4 weeks to affect the ability of E. coli to adhere to the urinary tract. Cranberry juice can be an irritant to the bladder with interstitial cystitis and should be avoided by patients with this condition. Avoiding caffeine, carbonated beverages, and tomato products may decrease bladder irritation and promote comfort during cystitis. A warm sitz bath 2 or 3 times a day for 20 minutes may provide comfort and some relief of local symptoms. If burning with urination is severe or urinary retention occurs, teach the patient to sit in the sitz bath and urinate into warm water. Urethritis is an inflammation of the urethra and can result from infectious and non-infectious conditions. The incidence is highest among adults ages 20 to 24 years. The most common cause of infectious urethritis is sexually transmitted infections such as gonorrhea, chlamydia, or trichomonas. Many women have urethritis have symptoms similar to cystitis, vaginitis, or cervicitis. Men with urethritis may report symptoms of cystitis as well as heaviness in the genitals. Symptoms of urethritis include discharge of mucopurulent or purulent material, dysuria, and itching or discomfort of the area. The discharge can be any color depending on the infecting organism and source of irritation. Additional symptoms may include fever with or without chills and urgent or frequent urination. Ask the patient about a history of STI, painful or difficult urination, discharge from the penis or vagina, and discomfort in the lower abdomen. Urinalysis may show pyuria or white blood cells in the urine without a large number of bacteria. All patients with urethritis should be screened for STIs, and the proper antibiotics should be used for any STIs that are diagnosed. A pregnancy test is performed for women who have had unprotected intercourse. Urethroscopy may show low estrogen changes with inflammation of urethral tissues. Non-infectious urethritis symptoms usually resolve spontaneously over time regardless of treatment. Postmenopausal women often have improvement of symptoms with the use of estrogen vaginal cream.